When we think about a medical miracle, we usually think of it as this really clean victory.
Right, like a clear-cut win.
Yeah, exactly. Like you have a pelvic or an abdominal tumor, you undergo radiation therapy, and the radiation acts as this incredible life-saving cure. The tumor's eradicated. You survive.
Which is obviously the ultimate goal.
Right. But then if you step back and kind of, look at the cellular battlefield left behind in the pelvis, this really fascinating and honestly almost cruel medical paradox emerges.
It really does.
Because what happens when the exact cure for one disease fundamentally alters the mechanics of the healthy tissues that are, just left behind?
Yeah, it is a profound paradox. I mean, oncology and urology have been wrestling with this for decades.
I can imagine.
We focus so intently on the primary objective, right? Destroying the malignancy. And because of that, the slow, insidious changes to the surrounding healthy anatomy, they often go completely unnoticed until years later. Yeah. We're looking at a landscape where the fundamental physics of your body have been entirely rewritten by, the very treatment that saved your life.
It's just wild to think about.
Yeah.
But anyway, welcome to this deep dive. Today's mission is for you to unpack a highly specific but profoundly impactful chain reaction.
Yes, a very specific one.
We're exploring exactly how a history of pelvic radiation causes these lasting changes in the elasticity of the urethral sphincter, which, as we'll see, very often leads to severe long-term incontinence.
It's a huge quality of life issue.
Exactly. And we're synthesizing a massive stack of complex clinical data to guide us through this today. We're diving into advanced shear wave elastography imaging studies, histological research mapping cellular trauma in animal models, and these really comprehensive clinical reviews of post-radiation urological complications.
And, synthesizing these diverse fields is crucial because this isn't just a surgical problem.
Right.
And it certainly isn't just a radiological problem either. We are looking at a biomechanical failure that is deeply rooted in a progressive cellular trauma.
So it's systemic to the area.
Exactly. If you only look at the final mechanical failure, you completely miss the underlying disease process that caused it.
Okay, let's unpack this. Before we can even begin to understand the mechanical failure of the sphincter itself, we first have to, understand the cellular environment that radiation leaves behind in the pelvis.
Right, setting the stage.
Yeah, because more than 50% of cancer patients receive radiotherapy at some point in their treatment.
That's a massive demographic.
It is. And while survival rates for breast, cervical, genitourinary, and rectal cancers have soared, which is amazing, the collateral damage to adjacent tissues is just immense. We're talking about healthy muscles, blood vessels, and dense nerve networks all getting caught in this ionizing crossfire.
And that crossfire is brutal at the cellular level. Ionizing radiation causes massive direct DNA damage, and it triggers the formation of reactive oxygen species within those healthy cells.
Which sounds bad.
It's very bad. This overwhelming oxidative stress leads to widespread apoptosis, or cell death, throughout the entire irradiated field.
Okay, so a lot of the healthy cells just die off immediately.
Right. But that acute cellular death is really only the beginning of the long-term story. The real driver of the chronic changes we see, years later, begins with this vascular process known as obliterative endarteritis.
Obliterative endarteritis. That essentially sounds like the blood vessels are scarring themselves shut.
That's exactly what it is.
So if the delicate endothelial cells lining the small blood vessels are damaged by the radiation and those vessels slowly obliterate or close up, the entire vascular supply to that region is just choked off.
Precisely.
Which means those surrounding tissues must be absolutely starving.
Oh, they are. When you lose your microvascular supply, the resulting localized hypoxia, which is a lack of oxygen and tissue necrosis, set off this relentless cascade.
Wow.
The local tissue environment fundamentally changes because it's no longer receiving the oxygen or, frankly, the systemic nutrients required to maintain normal cellular homeostasis.
It's essentially like salting the earth after winning a major battle. Like the tumor, the enemy, is completely destroyed.
Great analogy. Yeah.
But the local supply lines, those critical small blood vessels, are just completely ruined in the process. The remaining healthy cells in the area can't thrive, they can't get reinforcements from the immune system, and they definitely can't rebuild the local architecture properly.
Exactly. And because the earth is salted, the tissue's survival mechanism kicks in, which basically happens in two distinct phases.
Okay, what's the first one?
Initially, there's an acute inflammatory phase. So in the weeks following radiation, The area is characterized by hypersemia, severe edema, and a massive spike in localized inflammatory activity.
Just swelling and redness everywhere.
Right. The body is desperately trying to heal a wound in an environment that can no longer support normal healing.
Because the supply lines are cut.
Exactly. Then, over time, and this can range from several months to several years, that acute inflammation subsides, and the tissue enters a chronic, completely irreversible fibrotic phase.
Wow. Okay, so if the healthy, flexible tissue is literally being replaced by fibrocytes, that is going to drastically change the architecture of whatever organ we're looking at.
Completely changes it.
Because these fibroblasts are essentially just dumping down rigid scar tissue, right?
Mhm.
And in this hypoxic environment, they cannot synthesize collagen properly. The collagen bundles become all disorganized and dense.
Yeah. The tissue essentially forgets how to be a dynamic functioning muscle and gradually just becomes a rigid, static scar.
That's so grim.
It is. And this is a progressive cascade. It's not an immediate overnight loss of function. It's this slow, silent transformation of the tissue's very nature. It operates entirely under the radar until a critical threshold of mechanical failure is finally reached.
Which brings us right to the actual hardware we are focusing on today, the urethral sphincter.
The main event.
Right, so if this progressive salted earth fibrosis is constantly operating in the background, we need to know how it specifically alters the physical structure and the mechanics of the sphincter. We know the normal striated muscle is being replaced by disorganized connective scar tissue.
Yes.
And I was looking at the high-resolution MRI data, and it paints a really stark picture of physical atrophy in these patients. The actual muscle mass is just vanishing.
It's really dramatic when you see it on the scans. When radiologists use endovaginal coils to get a highly detailed look at the pelvic floor in women suffering from post-radiation stress urinary incontinence, the physical shrinkage of the sphincter muscle is undeniable.
How much shrinkage are we talking about here?
Well, we're looking specifically at the striated muscle layer of the urethra, right? The crucial part you actively control to stop urine flow. In healthy continent patients, that muscle layer has a robust mean thickness of about 2.6 millimeters.
Okay, 2.6 millimeters.
But in the patients presenting with stress urinary incontinence after radiation, that muscle layer has atrophied down to a mean of just 1.9 millimeters.
Oh, wow. Going from 2.6 millimeters down to 1.9 millimeters is a massive, catastrophic loss of muscle mass for such a tiny, precision-based anatomical structure.
It's a huge percentage of the total volume.
You're losing a huge chunk of the bulk required to physically close off the urethra. But it's clearly not just about the size, right? It's about the texture, the compliance, and like the flexibility of what's actually left behind.
Right, the material properties.
Yeah. I was looking at the shear wave elastography imaging, or SWE, which, from what I understand, uses acoustic radiation force impulses, basically targeted sound waves to quantitatively map how stiff a tissue is in real time.
That's correct. It's a brilliant technology.
And they measure this stiffness using a metric called Young's modulus.
Yes, Young's modulus is a fundamental mechanical property. It measures the stiffness of a solid material, basically quantifying how much force is required to deform it. The higher the kilopascals, or kPa, the stiffer and more unyielding the tissue is. And the shear wave elastography studies found that these fibrotic incontinent urethras have a drastically higher Young's modulus across the board.
Give me the numbers.
In the middle portion of the urethra, healthy continent patients demonstrated a tissue stiffness of about 30.7 kPa. But in the patients with post-radiation stress urinary incontinence, that stiffness metric rocketed up to 57.8 kPa.
Okay, wait. I have to push back here for a second because this feels deeply counterintuitive when you first think about it.
How so?
Well, if the tissue has a significantly higher Young's modulus, meaning it is demonstrably stiffer and more rigid, wouldn't it be tighter? Like, wouldn't a stiff, rigid tube hold liquid better than a soft one? Why does a stiff sphincter automatically equal a leaky one?
What's fascinating here is that we often conflate rigidity with strength or structural integrity.
Oh, wait a second.
In the biomechanics of the human body, and specifically in the urinary tract, true continence requires elasticity, not just rigidity.
It has to move.
Exactly. An optimal Young's modulus allows the tissue to be highly compliant. It needs to dynamically stretch, compress, and instantly adapt to sudden, extreme changes in intra-abdominal pressure without ever compromising its watertight seal.
So the sphincter needs to be able to move and react. It's kind of like comparing a brand new rubber band to a dried out, brittle rubber band you find in the back of a junk drawer.
That is the perfect way to look at it.
A fresh rubber band is highly elastic.
Mm,
It can wrap tightly around something, easily expand when you pull it, and then instantly snap back to form a perfect continuous seal.
right.
But the fibrotic urethra is acting exactly like that rigid, dried-out rubber band. It might technically be harder and stiffer to the touch, but it completely lacks the dynamic compliance to adapt and form a watertight seal when the pressure in the environment suddenly changes.
Exactly. And the clinical term for that sealing ability is coaptation. When your intra-abdominal pressure spikes, a healthy elastic sphincter dynamically clamps down tighter, increasing its internal resistance to perfectly match the external pressure.
So it fights back against the pressure.
Right. But a stiff, fibrotic, irradiated sphincter cannot compress itself to seal the lumen. It operates as a rigid, scarred tube. And because it has simultaneously lost its muscle mass, dropping down to that 1.9 millimeter thickness, it simply lacks the physical bulk to close the gap, even if it could somehow receive the neural signal to do so.
Man. So if the sphincter is stuck as this rigid, atrophied 1.9 millimeter tube that physically cannot compress, what happens when that patient simply goes about their daily life and coughs or laughs or lifts a heavy grocery bag out of the car?
That structural failure manifests clinically as stress urinary incontinence, or SUI. Because the sphincter cannot dynamically react to maintain coaptation, any mundane activity that suddenly increases intra-abdominal pressure forces urine directly past the rigid sphincter.
So literally just everyday movements.
Yeah. Even seemingly minor physical exertions, like changing body positions from sitting to standing, can result in immediate involuntary leakage.
And it isn't just the tube itself falling apart, is it? It's the entire architectural hammock supporting it.
Yes, the support system is crucial.
The surrounding ligaments that hold the urethra in place have also been caught in that exact same cellular battlefield of radiation. We're talking about the periurethral, paraurethral, and pubourethral ligaments. They are responsible for anchoring the urethra firmly against the pelvic wall.
Right. They form a highly tensioned, supportive suspension system. But because the obliterative endarteritis and subsequent fibrosis affect the entire irradiated field, those ligaments undergo the exact same rigid scarring and structural decay.
So they get brittle too.
Yes, they elongate, they tear, and they lose their tensile strength.
Here's where it gets really interesting, because the disparity in the ligament data is just staggering. I was looking at the distortion rates, and 83% of the incontinent patients presented with severely distorted paraurethral ligaments on their MRIs.
Which is massive.
Compare that to just 19% in the healthy controls. And for the paraurethral ligaments, it was a 56% distortion rate versus 13%. It's a total systemic failure of that entire hammock structure.
It really is.
When that supportive hammock is shredded by fibrosis, the urethra loses its anchor. It just drops when placed under physical stress.
And the metric used to quantify that drop is called bladder neck descent, or BND.
Oh, right.
It measures precisely how far the bladder neck and proximal urethra plunge downward under sudden physical stress. In healthy, continent individuals with intact ligaments, the descent is relatively minimal, averaging about 10.5 millimeters.
Okay, 10.5.
But in these post-radiation incontinent patients, the hypermobility is severe. The bladder neck descent plunges down to an average of 21.8 millimeters.
Wait, that is more than double the downward displacement. So the bladder neck is basically falling through the pelvic floor every time they sneeze.
Exactly, which is precisely why this specific condition, clinically categorized as a form of intrinsic sphincteric deficiency, or ISD, is so uniquely devastating and difficult to manage.
Because everything is broken at once.
Yes. The anatomical damage is highly multi-layered. The sphincter isn't just dealing with a localized minor mechanical injury. It is actively losing its functional nerve supply, its striated muscle tone, its cellular elasticity, and its exterior architectural hammock support, all concurrently as a result of that initial radiation exposure.
I mean, how do you even begin to fix a structural failure like that? Knowing exactly how and why this mechanical failure happens, that the sphincter is basically a thin, rigid, unsupported tube existing in a hypoxic, salted earth environment, how in the world does modern urology repair tissue that has virtually no blood supply?
Well, historically, it has been an absolute nightmare for pelvic reconstructive surgeons.
I bet.
Surgical interventions in a previously irradiated pelvis are notoriously difficult and fraught with catastrophic complication rates. The standard surgical fixes for severe incontinence rely heavily on manipulating local tissues and the body's innate ability to heal post-surgery. We use techniques like excision and primary anastomosis for urethral strictures, or the placement of synthetic urethral slings, but as we established with the obliterative and darteritis, the blood supply required to heal those surgical incisions simply does not exist anymore.
Right. You are making incisions in tissue that is already starving. There are no supply lines to bring in the inflammatory cells and nutrients needed for standard postoperative healing.
Exactly.
I would imagine that placing synthetic materials, like an artificial urinary sphincter, into that environment would be highly risky. If you place a mechanical inflatable cuff around a urethra that has no blood supply and zero elasticity, that rigid tissue is just going to break down under the constant pressure of the device.
It does. Radiation therapy is universally recognized as the single strongest independent risk factor for the erosion and failure of an artificial urinary sphincter device.
Really? The strongest risk factor.
Yes. The clinical outcomes are stark. Studies tracking these devices show that radiated patients experienced a severely truncated erosion-free survival timeline.
How truncated?
A median of just 1 year before the device eroded through the dying urethra. Compare that to 3.15 years of erosion-free survival in non-radiated patients. The tissue simply cannot withstand the mechanical friction without a robust blood supply to continuously repair the microtraumas.
So because surgery is so deeply compromised and dangerous in these irradiated tissue beds, the scientific and medical community seems to be executing a massive paradigm shift.
We have to.
Instead of waiting for the tissue to become a dried-out rubber band and then trying to mechanically fix it after the fact, the focus is pivoting rapidly toward targeted antifibrotic therapies. The new objective is to stop the loss of cellular elasticity before it ever becomes permanent.
Exactly. We are seeing a major push toward pharmacology over pure mechanics. If we know that the initial radiation injury triggers a predictable biphasic cascade leading to fibrosis, the logical intervention is to interrupt the specific molecular signals that command the tissue to form those disorganized scars.
And this brings us to the really cutting-edge pharmacology currently being investigated. There is an enormous focus right now on a drug called pirfenidone, which is being actively tested for this exact application in the pelvis.
Yes, pirfenidone.
It's an oral medication, right? A systemic drug designed to halt this localized scarring.
That's right. Pirfenidone works by modulating the TGF-beta-1 signaling pathway. TGF-beta-1, or transforming growth factor beta-1, is essentially the master regulator of fibrosis throughout the human body.
Okay, so it's the boss of scar tissue.
Basically, yeah.
Yeah.
Under normal circumstances, it helps manage standard wound healing. But when tissue is subjected to the massive, unnatural trauma of ionizing radiation, the TGF-beta-1 pathway goes into absolute overdrive.
So it panics.
Exactly. It aggressively activates fibroblasts and commands them to continuously deposit massive amounts of dense collagen, which rapidly forms that rigid, inelastic scar tissue we see on the MRIs.
So by modulating that specific pathway, pirfenidone effectively suppresses that runaway collagen deposition. It dampens the early inflammatory responses that trigger the cascade.
Right, it interrupts the signal.
It acts as a reversible inhibitor of fibroblast activation. It is basically circulating through the bloodstream, reaching that irradiated pelvic tissue, and telling the cells, hey, stop paving over this functional striated muscle with concrete.
Great way to phrase it, yes.
And by halting that process early, it preserves the vital structural integrity of the anal and urethral sphincters, allowing them to maintain their contractile function and their elasticity long after the radiotherapy is complete.
And its antifibrotic and anti-inflammatory efficacy is actually already well established and FDA approved in other devastating fibrotic conditions, most notably idiopathic pulmonary fibrosis, where it preserves lung compliance.
Oh, wow. So it's already a proven concept in the lungs.
Exactly. Now it's showing profound, measurable promise in mitigating radiation-induced injury in the urological system. It beautifully bridges the gap between understanding the exact cellular pathophysiology of the radiation damage and delivering a highly targeted molecular intervention to preserve gross anatomy.
So what does this all mean? How do these pharmaceutical breakthroughs actually change the landscape for you, the patient, or anyone currently facing the daunting prospect of pelvic radiation?
If we connect this to the bigger picture, it means the future of urology and pelvic oncology is moving away from purely reactive salvage mechanics.
Thank goodness.
Right. It's no longer just about cutting out necrotic scar tissue or attempting to implant synthetic devices into a hostile avascular environment where they are, frankly, destined to erode. The future is grounded in preventative medicine at the molecular level.
Getting ahead of the problem.
Yes. It is about understanding that radiation initiates a highly predictable cascade, and we now possess the pharmacological tools to step in, break that chain reaction, and proactively maintain the tissue's natural elasticity before the architecture is permanently lost.
It really is a remarkable journey when you step back and look at the entire process we've traced today. We started with the concept of radiation acting as a salted earth weapon, destroying the primary tumor, but simultaneously obliterating the micro blood vessels.
The obliterative endarteritis.
Right, causing severe localized hypoxia and triggering a relentless TGF-beta-1 driven fibrotic response.
Mhm.
We saw exactly how that molecular scarring physically shrinks the striated muscle of the urethral sphincter from 2.6 millimeters down to a mere 1.9 millimeters,
Mm.
effectively turning it into a stiff, rigid structure.
A literal scar.
Yeah, a stiffness that we can now quantitatively measure and track using shear wave elastography, watching it jump from 30.7 kPa all the way to 57.8 kPa.
It's all connected. And we broke down how that increased stiffness, combined with the fibrotic destruction of the supportive ligament hammock and a massive increase in bladder neck descent, leads directly and inevitably to the mechanical failure of stress urinary incontinence.
Because the body is just systematically stripped of the elastic compliance and structural tools it requires to hold back routine intra-abdominal pressure.
Yes.
But ending on the promise of targeted anti-fibrotic drugs like pyrfenidone reminds us that while the fundamental mechanics of the human body are incredibly vulnerable to these intense, life-saving therapies, human ingenuity is finding brilliant ways to protect those mechanics at the most microscopic level.
It's a very hopeful frontier.
It really is. Before we wrap up this deep dive, I want to leave you with one final lingering thought based on the clinical data we've unpacked today.
Okay, let's hear it.
So, we know that radiation cystitis and the resulting fibrosis have a distinct latent phase. There is a silent period lasting months or sometimes even years where the acute inflammation has died down, but the irreversible chronic scarring hasn't fully set in yet.
Right, that quiet window.
During this window, the patient might feel perfectly fine. They might think they're completely in the clear. Now imagine combining that silent latent window with the new shear wave elastography technology we discussed, which can precisely measure the exact stiffness of the urethra in kilopascals in real time.
Oh, that's an interesting thought.
Could the future of post-radiation urology involve routine, predictive SWE scans during this silent latent phase? Imagine a world where your doctor catches the very first microscopic micro-stiffening of your urethral sphincter on a routine follow-up ultrasound.
Catching it before it cascades.
Exactly. They immediately deploy a targeted antifibrotic like pyrfenidone to halt the TGF-beta-1 cascade and stop the scarring in its tracks before you ever experience the mechanical failure and before you ever leak a single drop of urine.
That would change everything.
It really would. We might just be looking at a highly targeted future where the cure for cancer no longer comes at the devastating cost of your body's fundamental mechanics.